Good afternoon. It's my first time at INJECT, and I'm really pleased to be here with you today to present some recent work we've been doing on disparities in HIV and hepatitis C retesting rates among people who inject drugs in our setting. I just want to thank my two mentors, Hansel Tux and Tyler Bartholomew, for their support. So I'm sure everyone in this room is very well familiar with the fact that repeat testing for HIV and hepatitis C is critical for timely detection, linkage to care, reduced transmission, and improved treatment outcomes. Specifically, the WHO and the US CDC recommend that key populations, including people who inject drugs, be retested at least annually. But the question is, are we meeting those standards? So we sought to answer this question among participants of our SYRINGE services program in Miami. To give you a bit of insight into the context, the IDEA Miami Syringe Services Program was established in 2016 as the first legal SSP in Florida. We serve over 2,300 participants at our fixed and mobile sites with a comprehensive package of harm reduction services. We used administrative data from a 5-year time period directly after implementation of an opt-out testing program, covering just over 1,500 participants to determine what percentage of them were retested for HIV and hepatitis C within a year, and looked for sociodemographic factors that might have influenced retesting rates. So what did we find? Of the participants who were eligible for HIV retesting, so those who did not have a positive test on enrollment, only 16% were retested within a year. And of those 6 were positive results. For those eligible for hepatitis C retesting on enrollment, only 15% were retested within a year with 25 positive results. In terms of factors associated with retesting, for HIV, we found that homelessness and type of health insurance, specifically being uninsured, were associated with higher rates of retesting. This might seem counterintuitive, but it suggests to us that this is the profile of participants who are most likely to be engaging with our services on a regular basis. Relationship status was also associated, which might point to broader social factors influencing engagement in care. For hepatitis C, we found that non-Hispanic ethnicity was associated with higher retesting rates, and this points to potential disparities in terms of how Hispanic and non-Hispanic participants are accessing and engaging with our services. So our key takeaway: despite offering free, low-barrier testing services at a harm reduction setting that has a really high degree of trust and engagement with our participants, in that sample, only 5% of participants didn't return within a year that was under study, the retesting rates are still strikingly low and far beyond what's recommended in national and international guidance. And so this isn't a sophisticated analysis, but it's really important for us programmatically and underscores the need for additional implementation strategies or adjunctive interventions to align our retesting rates and support our community to meet those goals. We're currently doing qualitative work to explore barriers at the organizational and participant level, and plan to do an interrupted time series analysis to identify or to analyze those identified interventions or strategies. Thank you very much.